And it's also going to be sent live to Facebook. So I'm going to go ahead and do that while we're waiting for everyone else to get on. Whoever's typing like a maniac, congratulations on your fast typing, and maybe mute yourself. They'll just keep admitting people as they come in while I'm going live to Facebook, okay?
Okay, let's see. Yeah, there's Julie Riskin. Welcome, Julie. Patty Sullivan. Hi, Patty.
Welcome, Ray Allen, my neighbor. Bellevue Hale neighbor. Welcome to Alan Johnson.
I'll welcome the couple of Illinois folks that are on.
Good.
Okay, welcome everyone. We are live on Facebook, and my name is Sarah Wright. I'm with the Colorado Foundation for Universal Healthcare. And to do more official welcoming is Bill Semple, our board chair. Bill.
Well, welcome everyone indeed to our Shattered event. And this is an auspicious day. 57 years ago, on July 30th, 1965, President Johnson signed Medicare into law. So happy birthday, Medicare. Happy birthday to you. This was a great step forward for our country in the direction of moving to have our healthcare seen as a public good. Just like our fire departments, our public education, and our national parks. It's a great step forward, but it's not all celebration. We have an active looter in our healthcare system, including in Medicaid and Medicare, and that's the profit motive that shatters our healthcare. The insurance, drug, and hospital corporations have become a legal price-fixing cartel. And so return on investment is overpowering the years of training, experience, and wisdom of our providers. So in the face of this active shooter, we don't duck and cover. We stand up and we speak out. This series of events, the Shatter series of events, aim to link the various arms of our social justice movement and to speak up for meeting our human needs with equity. Our goal is to dissolve the silos and highlight the intersection of our compassionate work in each other's spheres. The poverty that's induced by how we pay for our health care is actually one of the major drivers of the social determinants of health that then create the disparities that we're so often seeing in our healthcare now. A recent Robert Wood Johnson survey in Colorado showed that in reaction to this, Coloradans want big fundamental change from our government for healthcare. And also in line with this, the Healthcare Cost Savings Act Task Force report from last September clearly has documented that a single nonprofit way to pay for our healthcare is a way to cover all of us. It'll cost us less, and it'll support better healthcare. In Colorado, we're looking at big changes coming soon. There's a two-step process in the works that already has a sponsor in the Colorado House and Senate to, as a first step, refer the essential features of a robust, single, non-for-profit way to pay for healthcare to the November 2023 election. And if that passes, the second step would be the implementing legislation that would be created based on these essentials. We'll keep you informed about this because this could be our way forward. Today, we'll address the interrelated issues of mental health, environmental health, and the disability community, and how all of us benefit from universal health care. Housekeeping note, you'll notice that you're all muted, but indeed our voices matter. And so put your comments and questions as they come up into the chat. And after our speakers complete their presentations, we'll have a Q&A. So now I'll turn things over to Sarah Wright to introduce our speakers. Thank you.
Thank you, Bill. We appreciate everyone for joining us today on this beautiful Saturday for such an important topic, including Lee Thompson, who is a licensed clinical psychologist in Colorado Springs. She earned her bachelor's at South Carolina State University and her master's in counseling psychology and doctorate in clinical psychology from Adler University in Chicago. Her experience includes assertive community treatment, correctional inpatient and residential treatment, and community mental health. She's a sensitive and trauma-informed clinician with a passion for working with adults with coping challenges due to serious and persistent mental illness, cultural traumas, anxiety and mood disorders, and navigating life's transitions. She serves on the board of directors for the Colorado Foundation for Universal Healthcare, and we are thankful to have her here today. Lee, welcome.
Hi, everyone. Thank you so much for that introduction, Sarah. Good afternoon, everyone. It's great to see everyone here for such a great event and very important discussion topic. So like Sarah mentioned, I am a licensed clinical psychologist here in Colorado Springs, and I have worked in practically every sector of mental health. I have served in the Colorado Springs community for the past 9 years and have really seen how insurance barriers cause risk to life and decline of quality of life. When the COVID-19 pandemic started in 2020, it was immediately overwhelming for the mental health community, not solely due to the significant loss of life and grief that came with thousands of lives lost, but also due to isolation, health anxiety, and fears of contracting the virus, increased substance use and self-harm behaviors, increased depression and suicide risk and completion, and national social justice and economic stressors. All mental health providers were then forced into telehealth, a world pretty foreign for many, but a necessary and impactful step in the mental health world. As we are on Zoom today too, I think it's kind of great that I'm going to talk a little bit more about how telehealth has been a really great advantage for mental health and how insurances make that possible, but also make that complicated. So we soon learned how much telehealth was providing more access for the community and state than we'd ever seen before. So I'm going to spend some time explaining that a little bit more. Telehealth was something that was rarely used in the mental health world and is now likely the most accessible way for people to receive services. Telehealth expanded access across the state and even across the country to simply increase access for individuals struggling with their mental health and physical health needs. Prior to the pandemic, Colorado Medicaid plans operated under regional accountable entities called RAIs, which were created to help increase mental health support to specific regions of the state. Prior to the pandemic, Medicaid clients and providers were only able to work together if they were in the same identified RAI, which in fact limited access if providers were either overwhelmed with their caseload and could no longer accept new clients, or if there simply was not enough eligible or qualified providers to meet the community's needs. This created wait lists and many individuals going underserved or not served at all. For those who were able to have means to internet access, this provided a much greater pool for access and provider choice. This allowed for individuals to seek out a larger variety of providers that may not exist in their community and may better meet their needs. mental health providers across the country have actively been trying to find ways to meet the needs of the mental health community by creating programs like PsychPack, a jurisdiction program allowing licensed psychologists like myself to see clients in 34 states across the country. And Counseling Compact, a jurisdiction program for licensed professional counselors that is currently on its way to be enacted in 10 states across the country. Colorado has already enacted these compacts, so many providers can expand their reach. I'm a part of the PsychPack program, and it's been really great to be able to have more reach for people across the state or in other states that find they don't have enough access to providers in their area. My niche population are Black, Indigenous persons of color, so BIPOC, and they are very limited BIPOC providers in the state and nationally. Despite my practice being located in Colorado Springs, many of my clients now reside across the state in areas like Denver, Aurora, Greeley, and Commerce City, because they were able to connect with the BIPOC provider in their area. Programs like PsychPack and Counseling Compact increase the areas and access in areas with limited access to where BIPOC clinicians exist. This also increases access for those with other specific and specialized mental health needs and have limited access to skilled providers in their community or state. I also work with a lot of individuals with serious and persistent mental health issues who don't often have opportunity to see someone in private practice because needs might be too high, but they get overwhelmed by maybe some of their community mental health agencies and needing that support. So being able to have this expansion allows providers who have different skill sets to also provide care. Telehealth expansion reduces cost for the people served. Having the ability to be located anywhere and log in from a phone, laptop, or tablet increased client availability to attend sessions. Clients no longer had to drive across town, reducing gas costs and the need to time out public transportation, change a work schedule to be available, or pay extra for childcare just to have time to be in therapy. For low-income and elderly individuals who may not have had resources or the tech savvy to log into an internet session, they were able to participate in therapy telephonically. Many insurance companies also began to waive co-payment fees for clients as they engage in telehealth services versus attending in-office appointments. So now for what we're at risk of losing. Insurance companies have also made decisions about eliminating telephonic sessions. This means individuals without means to internet access will also go without therapy. I will say, as of yesterday, I was informed that Medicaid is also making some more steps in Colorado to actually add a new code to continue telephonic services, which was really great because that wasn't what I knew prior to this. So I was very happy to announce that. Many providers, to include myself, have also changed their business practices to operate either hybrid or solely telehealth, again, reducing access for those who may need in-office supports but are penalized with office co-payments. Insurance companies have made statements about potentially reducing the compensation toward providers for telehealth, with explanations that in-office care is more effective and be compensated at higher rates. This causes providers to leave panels and reduce access, and again, limit access to clients to receive the care that they need. Many of the BIPOC clients that I work with have made comments that if they didn't have access to BIPOC providers, they would go without support, to include therapy and medication management. This puts a marginalized population at further risk. Those with serious and persistent mental illness who struggle with attending in-person sessions, but increased attendance with telehealth will also go without. The risk of suicide, an already frightening high statistic in Colorado, will continue to increase without access to supports that meet clients' needs. The pandemic resulted in significant declines in employment, which also meant many lost access to insurance and were placed on Medicaid expansion plans. However, during the state emergency, individuals were not allowed to be dropped from Medicaid. This can change very soon, causing major interruptions in established care that could lead to termination or lack of follow-up in the future, again, creating larger unserved mental health communities. Colorado recognizes the need to increase mental health supports. This fall, the Center for Health, Work, and Environment will be collaborating with Colorado Consortium for Prescription Drug Abuse Prevention to assist Colorado employers in addressing issues of mental health and substance abuse. This will support many employers who struggle with mental health to get supports in their recovery. That is also supported by their employers. In June 2021, Colorado House Bill 21-1258 established a temporary behavioral health program called I Matter to provide access to mental health and substance use disorder for services for youth 18 through up until age of 21. However, that is going to be ending here pretty soon, I think in the fall of this year. Governor Polis also signed Senate Bill 2212 in July 2020 to expand telehealth services across the state and keep telehealth access permanent post the end of the COVID pandemic, which has been a really amazing thing that he did very early on. However, despite the state having this protection, at the end of the state health emergency, individuals with private insurance plans may lose telehealth as an option or have very nuanced ways in which they can continue that service. Colorado has actively made efforts to show up for our mental health community, but these programs are unfortunately short-lived or become too complicated to participate in. They will run out of funding due to the significant and increasing need of the community. Voting Medicare for All in Colorado will help sustain programming that the state clearly recognizes as needed. Mental health is healthcare. Voting Medicare for All will continue to support our mental health needs in a preventative, accessible, affordable, and long-standing way. Thank you.
Thank you, Lee. Thank you. That was so helpful for all of our understanding. Really appreciate you. And remember, if you have follow-up questions for any of the speakers, to put them in the chat. Our next speaker, Tom Wilson, is a disability and healthcare activist. He's retired from Access Living, a center of service, advocacy, and social change for people with all kinds of disabilities, led and run by people with disabilities in Chicago. He serves on the board of the Health and Medical Policy Research Group, the community board of the Chicago Cancer Health Equity Collaborative, and is a member of ADAPT, a disability rights organization that uses a social justice framework because disability rights are human rights. Tom is the past board president of the Illinois Single Payer Coalition. Health equity that includes people with disabilities is Tom's passion. Welcome, Tom.
Thank you, Sarah. Hello, I'm pleased to be included in this discussion. As a healthcare advocate and disability advocate, I want to address how Medicare for All would be a huge benefit to the disability community. To begin, I want to point out that there is an enormous overlap between disability and poverty. One study says that half of the poverty numbers can be explained by disability. We know that SSI, that many disabled people rely on, leaves one living below the poverty line. We know from research on social determinants of health that poverty is linked to poorer health. Medicaid, that serves the poor and disabled, can be difficult to get on, and many are uninsured and go broke before they qualify. Other issues with Medicaid include unequal criteria across states, low reimbursement rates to providers that can lead to poorer quality of care and less access to care. Many on Medicaid rely on safety net hospitals that are underfunded and have less technology and resources. The incentives are often to stabilize, but not to address underlying conditions. So early discharge is one consequence of relying on Medicaid. Medicaid managed care has blocked access to specialty care, to durable medical equipment, and the personal choice of providers for individuals with disabilities who often rely on their specialists. Being on Medicaid continues to be a barrier to work for people with disabilities, a barrier to moving to another state, as it takes a long time to qualify for this new plan. This is especially true for home care. Barriers also exist for in Medicare for people with disabilities. If you become disabled and have a significant work history, you'll still have to wait a year to qualify, and a COBRA is often too expensive for many. The health system has traditionally discriminated against people with disabilities in regards to personal autonomy, similar to the current attack on women's rights to reproductive choice by the Supreme Court. Some examples of disability discrimination include forcing people with disabilities into institutions against their will, forced medication for some patients, forced sterilization, and having children taken from parents with disabilities without just cause. This suggests that we need to protect the rights of people with disabilities in a universal healthcare system. This is a concern that advocates will need to face. However, universal inclusion helps address discrimination and inequality. We know that universal systems improve access to healthcare. Here are some examples. In England, it was shown that class differences in lifespan shrank due to universal care when the national healthcare system was adopted. In the USA, health disparities decline after people qualify for Medicare, and the racial differences decline for people getting care in the VA system. The stigma of disability would decline with a universal system. Our current class-based healthcare system provides what you can afford. Well-paid employer insurance usually means top-notch care. Medicare works well for most. Medicaid is a lifesaver for people with disabilities, but has the drawbacks mentioned earlier. Poor-paying jobs usually have crappy insurance. And of course, millions have no insurance. Even in this hierarchy of healthcare, nearly everyone is at risk of financial ruin and bankruptcy. Long-term care is healthcare. Our disability committee at the Illinois Single Payer Coalition has focused on making sure that long-term care is included in all universal healthcare bills. We have made it our priority. Long-term care is currently mostly funded by Medicaid. It suffers from the other weaknesses of Medicaid, meaning you have to be in poverty to qualify. We have developed policy papers with our demands. We have worked with others who see this issue as important, including Physicians for a National Health Plan. We have spoken at workshops and plenary sessions at the annual Healthcare Now conventions. We make home care the centerpiece of our advocacy, as we know that institutional care is often punitive, dangerous, and linked to poor care. We have been pleased to see that long-term care is included in both the House and Senate Medicare for All bills. We continue to work to improve both bills, and we are particularly critical of Senator Saunders' bill that excludes nursing home care by leaving them to state systems. This appears to be a dodge to make Medicare for All's price tag lower. We are working to make sure dental care, hearing aids, occupational therapy, physical therapy, and other specialty services are seen as medically necessary care. This is an issue especially important to people with disabilities, but clearly a benefit to all. Another area we support is finding the community health workers and peer health support. We demand no copays and deductibles. It has been shown that even small copays are a barrier for the poor and have no place in an equitable healthcare. There still exist physical, cultural, linguistic, as well as financial barriers to healthcare at some of our providers. So funding enforcement needs to be part of a true universal healthcare system. While our emphasis is on strengthening home care, we want all long-term care covered. I would note that only 6% or even less of US adults have long-term care insurance. Long-term care coverage is very expensive, and this makes it an issue for the middle class. And all except the very wealthy could benefit. It is an issue where we can build support for Medicare for all. We need to address workforce issues in long-term care. Uncompensated family care is still the largest category of people getting long-term care. We need to address this shortcoming through better wages and benefits and paying families. This is part of building a more caring society. Single-payer healthcare is an essential but not sufficient step in addressing our extreme economic inequality in the US. Medicare for All addresses health disparities more effectively than all other reforms that many policymakers who are tied to our for-profit healthcare system are proposing. As my former boss, Mark Bristow, a leader in the independent living movement, used to say, disabled people are the canary in the coal mine. And if you develop a system that works for people with disability, it's likely to work for all. I encourage you to reach out to the disability community to advance your outreach and efforts at inclusion. As we say in the disability rights movement, nothing about us without us. Thank you.
Thank you so much, Tom. Again, so educational, really appreciate your time. Let's do others. Thank you. The next speaker, Juan Roberto Madrid, is a public health professional with 33 years of healthcare experience, mostly through military service as a Navy Special Ops and SEAL. Through multiple humanitarian medical missions and combat deployments in various countries, Juan Roberto developed a passion for public health, global health, as well as public health education and promotion. After retiring from the military, Juan Roberto worked for some of Colorado's largest healthcare provider systems, such as Centura Health and Health One, as a paramedic and paramedic educator, learning a lot about those systems. He went on to earn his Bachelor of Science in Health Professions and then his Master's of Public Health from the George Washington University Milken Institute School of Public Health, with concentrations in health communication and marketing, as well as environmental health science and policy. Combining his passion for the outdoors and healthcare have combined in research on how climate change drought in the Southwest has impacted the physical and mental health of farmers and ranchers in the Colorado River Basin. Welcome, Juan Roberto.
Good morning, all. Thank you for having me. Happy to be here. A happy birthday to Medicare and Medicaid 57. As our previous speakers have said, this was a momentous occasion in having Medicare and Medicaid programs developed because they provide a safety net for millions of Americans. On the environmental health side, I currently work for an organization called Green Latinos, and we are a national nonprofit that is focused on environmental justice and environmental conservation as it applies to Latino, Afro-Latino, and indigenous populations. And I'd like to ask the group if any have heard the term your zip code determines your lifespan or your health status. And often we hear that up to 60% of your health is determined solely by your zip code. This is largely due to the nature of communities people reside in, such as whether it has wealth, whether or not there is strong community investment, whether there are hospitals, healthcare centers present, among others. And so taking into account the social determinants of health, we think about the environment, our physical environment, the built environment, and then we think about how that environment impacts us. Currently this weekend, the Pacific Northwest is under a heat advisory. And so the environment these folks live in, if you can afford air conditioning, you can afford.
Roberto, I'm so sorry. This is Sarah. Can I interrupt you? For some reason, your camera is moving a lot. Is there any way to stabilize it? If it's your phone, just like put your hand on a rock or something to stabilize it. It's just shaking. For the video, I just thought you might want to know that.
Yep.
Maybe you got wind going.
Okay, thank you.
Perfect.
Yeah, how's that?
That's much better. Thank you.
It's better.
Okay.
All right, let me try that. There we go.
We're just on a river trip with you, Juan.
Say again?
That's great. That's great.
Okay. All right. So we think of how the built environment impacts our health and impacts communities. And so we think about disproportionately impacted communities that are often being impacted by environmental conditions. We think about historic redlining that has placed disproportionately impacted communities in the brunt of industrial work sites which impact their health. And so often in these communities, healthcare is lacking. If you can find a job, that job is impacted by your health and your health care. And so we know in these disproportionately impacted communities, I'll use Northwest Denver, Commerce City, for example, where we have a refinery and we have a heavy trucking corridor, multiple warehouses with heavy trucks that come through the area, as well as rail yards and the environment there. And so we know that the folks who are living in these environments that often go to work are exposed to environmental conditions. Those environmental conditions are impacting their health. That impact of their health then impacts their ability to retain a job. In Commerce City alone, Adams County, the projections for 2023 are that folks will have 774 days of missed work or missed school. If you're a parent, you're taking that time off to get your son or daughter to a hospital for treatment or care. Often that results in loss of employment, reduced employment, and then a reduction of healthcare benefits. So having Medicare or Medicaid for all is then important for folks living in these disproportionately impacted communities, whether that be in our urban corridors or our rural and frontier corridors where they often lack access to healthcare. So our emphasis is on seeing universal health care for those options. We also think about our undocumented and immigrant communities. On the western slope of Colorado, we have many migrant farm workers that come into the area to harvest the food we eat, whether that be Olathe sweet corn or Rocky Ford watermelons or the peaches from Palisades. And often these migrant farm workers are not covered by health insurance. They're working at piecemeal rates. So the amount of produce that they pick per bucket that they put into the bin, that's how they're paid, but no health care is offered for them. Often these employees are also working in extreme heat conditions or extreme cold conditions, which then impacts their health. And then we think about the cumulative impacts that has. So we often see these individuals that might have diabetes, might have kidney disease, heart-related disease, high cholesterol, high blood pressure, and those conditions are impacted by those high heat conditions and the conditions they're working in. We often see in our rural community hospitals, these same folks come into the ER on a frequent basis and they don't qualify for care. So Medicare, Medicaid for all would improve the health and lives of these folks who come here on those work visas as well, because the employer provides no insurance for them. And so we look from the environmental health perspective and from the environmental justice perspective, we think that Medicaid and Medicare for all is a benefit for all.
Thank you, Juan. Roberta, we appreciate that so much. And after that, I just wanted to ask if there are any comments or questions that our speakers would like to make to one another before we open it up to the Q&A. Hi, Tom, did you have I thought you were about to ask a question, am I right?
Yes, I'm trying to frame it here. You know, managed care has been a huge problem here in Illinois. I think you have less of it in Colorado, but it's just another way for the insurance companies to get deeper into your business and control your health care. I was wondering, you know, what Colorado's people in Colorado have thought about that.
I can answer that for you, Tom, a little bit. I think that insurance companies do get in the way quite a bit of dictating how our work is done, the type of work that we provide, which is always really interesting because insurance companies are not trained mental health professionals or often healthcare professionals at all. And yet they can say what's medical necessity or not, which limits the way that we can provide care. I think that's why there's also a lot of mental health providers as a whole who often want to stay away from insurance or have worked with insurance for some period of time and eventually move to self-pay to have more control over the care that they can provide. And people then also have more ability for choice. So yes, insurance companies do make our roles very limiting.
Thanks, Lee. Anyone else on the panel want to ask something to another speaker on the panel? Okay, all right. Then if no, we're going to go ahead and go into the question Q&A, questions and answers. And I know that both Les and Maddie Jacobs were going to ask questions from the chat. You guys want to begin?
So my name is Dr. Les Reitman. I'm going to try and field the questions. The first one that came in from Reverend Alan Johnson. And he has a question about the parity law for mental health to be equal, I believe, to physical health care. Is it being enforced? Are people excluded by insurance companies if the law for parity is not being held, complied with in the state? So I'm going to throw this one open to all of our three panelists, if anybody knows whether Colorado has such a parity law.
Yeah, I saw you unmute yourself, and I thought that was probably a question for you.
Yep, no, perfect.
Okay.
I believe that Colorado does have parity law, but I don't think it's not so much about it being enforced. It's about how the insurance companies still dictate services within that. They do not reimburse by any means at the same rate that they do for physical health needs that they do for mental health, which is why a lot of providers leave networks and reduce availability for access. I think that they also will say, yeah, you can see these providers with these issues within your insurance, but then when insurance kind of gets into it, it's like, we're limited on that, or we might not say that that's a treatment that's for whatever your mental health need is. Even things like having to give certain diagnoses that may not be appropriate, but needing to do so in order for a person to get care. So I think that it just gets really complicated, that the parity law is something that should be enforced more, but I think it's very complicated and doesn't really get the kind of results that they're hoping for it to do, but giving that equal access to care, it's a lot easier for people to get their mental or their physical health needs taken care of than it is their mental health needs.
Thanks, Lee.
Okay, now I think that's an important point that you make. The next question is from Patty Sullivan, who has found that her new physician does not take Medicare, and so she's wondering how people can, if there's an alternative for that.
That's not what she's asking.
I'll throw that one open to the panel.
Yeah, I mean, it didn't sound like there was, because it sounded like they were just paying cash. And the provider there, she was very unhappy that they're not taking Medicare anymore. So, yeah. But
Yeah.
is there, I mean, what else would you do besides pay cash?
I'm going to call on Maddie Jacobs, who is one of the physicians for Universal Healthcare, as is Dr. Reitman. Maddie, let's have you make your comment.
Yeah. Thank you, Sarah. And that's a wonderful question, Patty. There actually probably is not an alternative in the current system, which is why we need a new system. So unfortunately, providers can have forgotten about their Hippocratic oath to serve people and to not cause harm. But in the current system, since it's totally driven by profit rather than healthcare, you know, patients are ghosted. Patients denied care. I just got through a year and a half of taking care of a sick sister who finally passed away, unfortunately, just a couple weeks ago. And we just had trouble getting care for her because people would refuse to take care of her. And unfortunately, this is what's happening with Medicare. It's being privatized, and people who don't want to support it don't take it, so you can't get care. I mean, it is all cash. And on top of that, as Tom briefly mentioned, Medicare is being privatized, and they have things like Medicare Advantage, which is, again, they're totally ripping off taxpayers, getting huge profits, and denying care by having narrow networks. So this is the perfect example of why we desperately need reform. And these issues would be resolved or have been resolved under other examples of single payer around the world. So I agree with you, Patty. It's pretty horrific.
I would just add that I've heard from various sources that dentists are particularly opposed to Medicare for all. And as we know, dental insurance does not cover a lot sometimes, or many people don't have it. And I think that's the vision that some of these boutique practices have. They want to get paid in cash or have a prepaid system that they're so they don't have to deal with the insurance companies. And that's one reason some of these doctors opt out, because they hate working with these insurance companies. It eats up all their time. But of course, most people can't afford boutique healthcare. So clearly we need a universal system that that includes all the providers. And there would be very few, I think, that opted out if the reimbursement rates were at all fair.
Yeah, Patty, this is Dr. Reitman. There's one thing called community health centers, which in Denver, I believe there are 7 of them. These are sliding scale cash, but they're much more reasonable priced. And this is something that Sanders was able to put $7 billion into. So you might check out community health centers in your area as not a perfect answer, but a more cost effective one.
Yeah, no, I'm not old enough for Medicare. I was just noting that my doctor does not take Medicare, and that there was some discussion there about that when I was into the doctor's office for a checkup recently. We were just talking about the fact that they don't take Medicare anymore. And I'm not even sure about TRICARE either, like how they're moving on that, but they basically don't take any government healthcare anymore. So, yeah, I had been with for many years, but go ahead.
I think one of the other issues with Medicare, even in traditional Medicare, the Medicare system has become enamored with what they call value-based purchasing, which is really profit-based purchasing. And this is even in traditional Medicare. They are trying to get away from fee-for-service, and they're getting much more bureaucratically involved in the decision-making, thinking that their thought is that fee-for-service incentivizes doctors just ordering all sorts of care that's unnecessary. And while there's a few examples of that, Americans by and large don't get too much healthcare. They get too little healthcare. And so I think so the bureaucratic overload, even in traditional Medicare, has gotten much greater in the last 5 to 10 years. And I think that's some of the reason that providers don't want to be working under those limitations. So that's part of getting to a improved Medicare for all. Part of that improvement is taking the bureaucratic interference between the decisions that doctors and patients make together to eliminate that interference, so that then providers can just feel free to give the best healthcare that their training, education, and years of experience dictate.
Thank you, Bill. Okay, let's go back to the questions in the chat.
This is again from Patty. I don't know if how long it will take to explain it, but it sounds like this is one of those health account cards, HRE. Patty, is that what you're talking about? Your employer puts aside a certain amount of money. Once you've paid $5,000, then you can use that money for your health care?
Yeah, no, the health plan, a lot of these health plans now are all you need to meet the deductible before they cover $1. So you'd have to spend $5,000 before they would cover the first dollar. And if it was a quote unquote regular appointment, if it's a checkup, that's fine, it's covered. But if it's anything other than a checkup, then you would have to pay for the whole appointment yourself, is the way a lot of these plans work. So this plan is like $5,000 deductible. However, the employer decided to load some money onto a card. So I thought, oh, cool, you know, I could just kind of take the card around with me and just use it. Well, not so much. It's quite an administrative nightmare, and I'm betting that the insurance companies probably bet on the fact that a lot of people won't do all that paperwork. They just won't make that kind of an effort because it's a lot, and that they won't get reimbursed, you know, and especially if it's something like $50 or something, you know. So I don't know. I think they need to make it a lot easier to administer some of this stuff, because I have a lot of extensive experience administering healthcare because my husband, you know, had a lot of health conditions. And, you know, it's just the amount of paperwork is crazy.
Thank you, Patty. Maddie, your hand is up. Is that new or?
Yeah, it is new. I just think that this is just another example of why we need a simple system instead of this fragmented system, which we will be talking about that as a thing that's happening in Colorado when we get through some of these questions. So, you know, this is just another example of profit rather than care.
The next question from Sandy was that she's confused with the different health policy groups in Colorado. So I'm wondering if Maddie or Bill could clarify what the health policy groups are. That's what we call somewhat silos. That's one of the reasons for this conference. Do you have any comment on that, Bill?
But I think healthcare policy is intentionally complicated because that's what can leave the opportunities for profit taking. So there, with the Colorado Health Foundation for Universal Healthcare, we're looking to develop a collaboration among a whole wide range of organizations to be working on getting in support of a referred ballot measure, so that speaks to the essentials of what a good healthcare working system is. Because I think that's been a missing piece. It's easy to get people distracted into different things that they don't like about healthcare, and it distracts people from just looking at what are the basics to be a good healthcare working system. And so that's one of the things we're working strongly on.
Thanks, Bill.
Okay, and then there was a question from, I believe, Laura, about my own Colorado insurance company's privacy agreement gives them access to my computer search history in order to use telehealth services, which I choose not to give them that information. So I wonder if Lilith, if you have a comment on if that's a barrier to the telehealth system, that people have to give too much personal information, if that could be improved.
So this is something that I think a lot of mental health providers are seeing to be very worrisome in our future with telehealth, unfortunately. Even recently, Amazon is trying to get into the market of doing things of this nature, which is going to not have those privacy limitations. And there have been discussions about how does HIPAA fall in line with this if these third-party agencies are using platforms to do telehealth. There are a lot of other mental health platforms that have kind of boomed throughout the pandemic, and some that I'm also a part of, where I've had even moments of like, what will this look like in our future? How will this impact the care that I provide, the way that people feel safe about having their information discussed and shared? Because that is a really big piece of having a lot of client privacy. And if there's an expectation to give up other things just for their healthcare to be in existence, is going to be problematic.
Wow.
Thank you. Yes, that's a good, very good point. Then we have a question from Kathy Blake, which is, how is the bill to reduce surprise billing working for Colorado? Maddie, I don't know, you've had a personal experience with a lot of big bills that your sister probably incurred. I don't know if you have any experience with surprise billing being enforced, that it's not, that there are restrictions on the hospital.
I've actually had, unfortunately, the same question of whether this is working, because a lot of the bills that my sister got, unbeknownst to her, were, quote, out of network, unquote. And she had no choice as to where she was going if she was transferred from one facility to the other, because the facility she was at had no beds, because they did not, they were getting rid of staff, closing wings like at Parkview, and she had no choice where she ended up going. And so she got a lot of bills. So if anyone does know how that is working in Colorado, I would love to know it. It's supposed to be a national bill as well as the Colorado bill.
I've heard that Kaiser Family Foundation can sometimes help people. I think you should refuse a surprise bill and force the billing.
Yeah, I think people just need to be aware of it, because I think you're right, but I also think that probably these are new bills and they didn't kick in until recently. So we'll see how it all pans out, but it's certainly not fair. And under a single payer system, there are no networks. There's no provider networks.
That's a big advantage.
Everybody's in that one.
And Mike McHugh has a question about that single payer will allow, if timely care. There's a question that people have to wait for certain things, and he uses the example of Canadian care.
Yeah, I'll address that. I've, from what I've seen, this is mainly a mythology. There may be cases in Canada where there's a local shortage of providers or a surgeon of a certain type, but for the most part, the waiting times in Canada are even less than the US. And I have my personal story about this. I was in Washington, DC, and went into intestinal distress. And it turned out I had an infected gallbladder. Well, they discharged me and sent me back to Chicago after they stabilized me a bit. And then when I went to my doctors here in Chicago, they said, oh, there's an 8-week waiting list for gallbladder surgery. And my infected gallbladder was still infected, and I was getting sicker and sicker. Eventually, I had to go to the emergency room, and they did the surgery on an emergency basis. But waiting lists in the US are way too long in some cases as well. And I think that, you know, in a more planned system, you'd look for the gaps in the system and try to reduce the wait times. And that's something that Canada and many of the other universal systems have been able to do.
Thank you, Tom.
Thanks, Tom.
Yeah, thanks, Mike. Because it's 5 of the hour and we want to respect everyone's time that you've given us an hour. We know that we didn't answer all the questions in the chat, and I will make the chat questions available to the panel and our team here at the foundation. We have all your emails, so hopefully someone can get back to you if there's a question we didn't answer for you today. And what I'd like to do is have Dr. Maddie Jacobs, who's the leader of Medical Professionals for Universal Healthcare, who's the host of this event, go ahead and give some closing remarks. Thank you all so much for being here. This video will be available on Facebook Live, and then there also may be soon available in other formats for those who do not like Facebook. Thank you. Maddie.
Thank you, Sarah. Yeah, we have had some questions in the chat about what's happening now to deal with this very tragic system that causes unnecessary debt and unnecessary death. So the first thing I just wanted to mention is how single payer, emphasize how single payer would ameliorate some of the social justice issues that we talked about today, because everything is interconnected. And given the deep pockets that we're up against, we need to be working together in melting silos. So the things that would help is, number one, a lot of questions came up today about the complications and fragmentation of the current system. Basically, that would go away. We would go from having administrative costs between 15 to 30% to, if it's like Medicare, less than 2%. People would not have to be spending all this time with trying to get care and trying to pay for care, because they would be paying for it up front. So what we're doing in Colorado is we actually have a two-step process, as Bill was talking about. And Sarah or somebody, if you could put the links to our website to those 10 essentials that are in the referred measure, that would be great. Oh, she just did. Thank you, Sarah. So what we are, basically what it is the referred measure would be referred by the legislature in the next session to go on the ballot next year, that would say what a single payer system should have in it. And then the legislature would be responsible for the second step to put out a bill that would do all those essentials. So that's what we're working on, and a lot of the essentials are what were mentioned by our speakers today, to ameliorate all the inequities that are in the current system. So the big problem with our current system is that it's about profit, and the single payer systems are about healthcare. And because of this, the goal would be the health of all, not the profit for the few, and to maximize health. Social determinants of health would be addressed to minimize the cost of the program. The healthier the people are, the less healthcare costs. Under the current system, it's designed to maximize health, number one, by maximize profit. Number one, by denying care. And number two, by ordering as much care as they possibly can, quote, care, or procedures and so on, even if people don't need it, to maximize their profit. So it's a totally cockeyed system. So we don't need to pretend or fantasize about what the system would show, because it is happening in countries that have single-payer universal healthcare systems. And in fact, for Medicare itself, when they passed Medicare all those years ago on today, we had an improvement of a lot of people's access to care at that time, including people of color and other disenfranchised communities, compared to what they had before Medicare was passed. So we can get this done if we melt silos, pull together, and support each other in the work that we're doing. And what you can do is get the word out to people you know and organizations that you work with. Check out our website, and again, Sarah put those links into the chat for actions that you can take and teams that you can join. Donate whatever you can. We're up against deep pockets. Monthly if you can, whatever amount you can, and that would be so appreciated. We'll be sending a follow-up email with links to the draft healthcare as well as the essentials ballot measure, Bill's article, and a lot more, and further information from our panelists, some of which has also been put in the chat from Tom. So thank you, everyone, for being here. You are very appreciated.
Thank you, Maddie. Everyone have a wonderful rest of your Saturday. Keep up the good work. We appreciate
Thank you, everyone.
Thank
Thank
you.
you, everyone.
Thanks, everyone.
Thanks,
Thank you all.
everybody.
Thank you.
Bye.
Thank you.